Hello, I'm Dr. Nalinkanta. In this second session of neonatal transport, today we are going to discuss about three main objectives. To get the best possible way in neonatal transport, the most important part is before initiating transport, how to stabilize the baby. So we'll talk about pre-transport stabilization and the process of actual transport, how to do it, and what are the quality markers and how to do it in the best possible way. And third objective will be reverse transport. I will come to that later. After stabilization of the baby in a tertiary level hospital, we will send back to the community health centers or the smaller hospitals that will cover in the reverse transport. So coming to the pre-transport stabilization, which is very, very important because transport goal should not be just transferring a baby or infant from one facility to other facility. It should be done in the best possible way to get the best possible outcome. So all goal of our all neonatal transport should be transport of a well stabilized infant. So to achieve that, we may follow any of the protocol, but here I am going to suggest when we are accepting a transport, let's follow the mnemonics of accept for the pre-transport stabilization. So what are the components of accept? Accept is A for assessment, C for control, C for communication, E for evaluation, P for preparedness and pre-departure checklist, and T for the actual transport. So how to achieve it? Let's come to one components. A for assessment. So before initiation of the transport, when we are speaking to the referring doctor or the referring facilities, we should clearly assess the situation. What's the problem? If RDS, respiratory distress, how severe it is? What are the equipments required? If it is a hypertension, how severe it is? How the fluid management will do? What inotropes required? What lines required? Those we should know before initiation of the treatment. So what management is needed now before transport, we will clearly will have idea. Then coming to the control. As per the NRP guideline, you will see in different sickness baby, if extreme preterm baby and antenatal risk factor baby, they propose to go for more skilled person like that in a transport to take the control. We to delegate the team leader role should be given, team leader and other members role should be delegated before the transport to take the complete control of the situation. And next C will be the communication. Communication is key to achieve everything right in the right time, right patient, right transport. To achieve that, communication is the key. So communication, whom to do the communication? The parents and family we should speak before initiation of transport. We should discuss with our colleagues who is referring in the referring hospital and at the referral hospital who is going to treat. Both the people should discuss before initiation of transport, and everything whatever the before transport initiation should be documented, and we should follow a protocol for this communication also. So we can follow a simple mnemonics is bar. Is bar, what are the components of the communication? First, we have to identify ourselves, who we are, who I am when I am speaking to somebody, who we are as a team when we are speaking to somebody. We have to identify ourselves. Then we should talk about the situation, what we are going to deal in the transport, and the background assessment, because all the facilities when we are going to get the babies may not be similar. It may be foam, it may be SNCU, it may be labor room, it may be investigation facilities. So we should check the background and assessment of the baby. As I clinically discussed, clinical assessment is primary important. After assessing everything, once documentation is ready, we should read back our information. So this is the ISBAR, we can communicate to achieve everything right. Then after the communication over, evaluation we should do, is the transport appropriate? Because very sick babies, when we're anticipating they can die within minutes before the transport, is the baby suitable for transport? Or the babies when require a very advanced treatment, advanced surgery, but the facility is not available at the receiving hospital, should we transfer to that facilities? To assess that, we should know is the transfer is appropriate. The evaluation. And after the evaluation, before initiation of the proper transport, our preparation, packaging, pre-departure check should be perfectly right. And to do that, we should get our equipment checklist should be ready, our medication should be ready. I will come to that later. But what we should do here, we should follow a protocol. So pre-transport stabilization, few protocols common, very popular protocols are available like stable, safer, stops, A, B, C, D, E, F, G. If stops, I will come stops is sensorium, temperature, oxygenation, airway breathing both includes here in oxygenation, and perfusion and sugar, the stops. A, B, C, D, E, F, G, very simple. A for airway, B for breathing, C for circulation, D for drugs, E for environment, surrounding, F for family, and G for guidance, the emotional guidance to the family. But to make it simple, we can follow the basic things. So before initiation of the transport, we should address the airway, breathing, circulation, stabilization is very key. And to do achieve that, along with other things, we can follow stable protocol. S for sugar, T for temperature, A for artificial breathing, and B for blood pressure, L for laboratory, like blood investigations, blood grouping, sugar, minimum test, if anything available, we should do that and carry the information with us. And the emotional support. And when you're changing from baby from one facility to other facility, the family moves to other facilities. That may be new facilities to new facilities to the family. So the emotional support during the sickness period is very, very important key step. And for neonatal transport, the why stabilization is important. Unlike a road traffic accident, here no place for soup and scoop. We should wait, we should stabilize, and to get the best possible treatment during transport and optimize the care, we should plan it properly. Then we know the majority babies who dies during transport, after transport, they require respiratory support during transport. 70 to 80% babies. 55 to 70% babies who dies later develop hypothermia during transport. So very, very key components to achieve this outcome. And 35% babies who dies later usually require circulatory support. So the major determinants of mortality during transport. This all three things should be taken care. So what should be our target? We should achieve those things. But how to achieve? Many modes of transports are there. I'm not going into detail those transport modes, but one for sharing a common information. If you don't have private transport system, 108 emergency service number available across many states of India. Calling that facilities, the vehicle, transport vehicle, the ambulance can reach to the referring hospital or the place and can transport between the facilities. And during our transport, to achieve the optimum outcome, the monitors are important. The pulse oximetry sometimes though give its oxygenation pulse information, and due to the artifacts of movements, it may not give us the right information. So we should see when we are giving a respiratory support, we should the chest movement is rightly chest movement is happening. And if the ET tube is there properly secured, and if preferably if ECG monitor is there to get to heart rate, it's better. So these are things should be available. In respiratory care, whenever required, CPAP, either dedicated CPAP or ventilation CPAP or a neopaf, TP resuscitator should be available during the transport to achieve the respiratory support. So these are all things which are optimized. And the medications also, the primary medications, basic medications should be with us when we are transferring a baby. The IV dextrose, normal saline, inotropes like dopamine, dobutamine, adrenaline, this should be available. Anti-seizure medications, including midazolam for sedation, should be available when we are transferring the baby. And when extreme preterm babies we are transferring, during the ventilation, if you feel surfactant required, we should carry surfactant. And the critical congenital heart disease babies, we should always carry prostaglandin E1 along with us to start whenever the transport starts. So these are the basic medications should be ready, and we should maintain the sugar, temperature, breathing, blood pressure support if laboratory required, and the emotional support is primary. This all we should achieve. But we should remember that among these all the things, the temperature case is very, very important in the small babies and VLW baby, very low birth weight babies, because each degree temperature low hypothermia can increase 28% mortality, as we know in the very low birth weight babies. So it's very, very important to monitor the temperature by a thermometer during our transport, and achieving the temperature care by the best possible way. Incubator facilities if available. Otherwise, embrace a thermal mattress is available that we can apply. If that's not available, at least by covering the baby with a polythene wrap, covering the head, which constitutes 25 to 30% body surface, with a cap, and kangaroo skin care with mother or father, the very important small simple steps we can achieve at least to reduce the hypothermia. When we're talking about hypothermia, we should achieve sometimes the cooling also by passive cooling or active cooling by miracradle if possible during transport, if we are treating a hypoxic ischemic encephalopathy baby during the transport. So we know the time and the team is very important to achieve the best possible outcome. But during the transport, we should see that baby is stabilized. Restrictions should be sometimes maintained. The disturbance we should prevent. And the transport proper, during the transport, our target should be keeping the baby warm by reducing hypothermia, keeping the baby pink. Whenever the baby is pale or cyanotic, we should assess the perfusion. We should assess the oxygenation of the baby. We should give either oxygen or respiratory support to keep the baby pink. And we should not forget to keep the baby sweet. So baby from labor room, SNCU, or from the home, whenever baby comes, at least these two things to be taken care of. Feedings we should not forget. So by feeding the mother milk, we can initiate breastfeeding, or we can express breastfeeding, we can give, or there is a feeding difficulty, you can put a nasogastric tube, some sort of feeding like express breast milk we can give. or if required, IV fluid you have to give to prevent hypoglycemia. These are key things when transferring of the baby. So skin to skin contact and feeding during transport should be done. Any stable, unstable babies, we should take care. But here, very, very important, when we are transferring the baby during the transport, to optimize the care, we should reduce the adverse events. So our response times should be right, and we should prevent unintended hypoglycemia, hypothermia, or dislodgement any of the instruments, or requirement of CPR should be minimal. Air leak we should reduce during the transport, and we should take care the transport related injury should not happen to the babies or the staffs, so that we can optimize our transport in the best possible way. And the baby deteriorates in the way like the during the respiratory support, or the baby deteriorates in the ventilator time in the unit and issues, we should remember to check for dope mnemonics. We should check it, and we should find out what's the reason of deterioration. And after the transport over, when we are getting the baby, once stabilized, we should not forget, because of the bed capacity of the tertiary level care facilities are limited. If the baby once stabilized, once received the definitive treatment like surgery, PD ligation at the tertiary level hospital, we should send back the baby to the referring hospital or the birthing hospital, which will decrease the cost of care. It will achieve the proximity of the baby to the mother of the family, and sometimes the appropriate distribution of the resources can happen if we are taking care of the reverse transport. So with this, probably our target should be common things to achieve, like temperature care, respiratory support, prevention of hypothermia and hypoglycemia, and achieving the circulatory care. With that, probably we can achieve the best possible with the neonatal transport. Thank you.